Please start, sir. We are live.
Yeah. Good evening, everyone. My name is Prateek. I'm from Bayer. I would like to invite, I would like to welcome you all on this scientific meeting from Bayer. I would like to invite Dr. Shailesh Parekh. Sir is an ophthalmologist and vitreoretinal surgeon practicing at Third Eye Clinic, Ahmedabad, a gold medalist from Gujarat University. Dr. Parekh has completed his Masters of Surgery in Ophthalmology, having done his fellowship of vitreoretina at Shankar Netralaya. He has delivered more than 65 research papers and posters and seminars in various national and international conferences. Just to expanding his area of service, in 2014, he has started a state-of-art eye clinic at Nairobi, Kenya, named INU Ophthalmics. So, Dr. Shailesh Parekh will be giving a talk on the evolving role of aflibercept in PCV, APVRS insight and comparisons with anti-VEGF agents. So, Dr. Parekh, over to you, sir.
Thank you very much, Pratik, for your introduction. So once again, good evening, a very good evening to all. And today I'm going to share my little knowledge in the treatment of one of the very common variant of neovascular AMD, and that is PCV. And that reminds me of my fellowship days, that when we were able to diagnose this variant of AMD, the PCV, most of the times the results were not very good. And PCV means, of course, there is a lot of treatment to the patients. And despite all the treatment, the visual impairment was most of the time it is there. So let's discuss today the evolving role of aflibercept anti-VEGF in PCV. We will discuss about some recent APVRS insights and also talk about some of the clinical trials and real-world study and comparison with other anti-VEGF treatment. So aflibercept monotherapy achieves clinically meaningful visual outcome in the patients with subtype of neovascular AMD such as PCV. So this is a short presentation on recent APVRS guideline. And to diagnose PCV, now it has become much easier with the OCT guidelines. I mean, most of the vitreoretinal surgeon and even anterior segment surgeons, now they have OCT. So whenever we see some AMD patient, and in particularly when we do OCT, if we see on OCT that end phase OCT complex RP elevation, that means very complicated RP, it's a large RP, pigment epithelial detachment. Or if we see very sharp peak PED, you can see some like inverted V-shaped PED or very large PED with M shape. Or if you see some sub-RP ring-like lesion, then probably, and with lot of bleeding clinically, at that time we suspect that this patient may have PCV. Of course, with other modalities of diagnosis like fluorescent angiography, ICG, and OCT angiography, it gives a lot of good information about PCV, but at least we do have OCT in almost all the centers. So once we diagnose this PCV, what are the options of initial treatment? So of course, the most common option is you start with any anti-VEGF monotherapy. You just monitor these patients in the response either on OCT or ICG. Now, if clinically there is no new blur, if on OCT there is regression of the fluid, edema, on ICG the polyps are showing regression, then probably you can gradually extend the interval with what we call as treat and extend regimen. But if there is a persistent or recurrence of disease, then there are three modalities. Probably either you can switch over to newer or some else anti-VEGF drugs. Probably you can reduce also shorten the interval with TNE regimen, or along with the anti-VEGF treatment, you can give a trial of PDT. Of course, so many times, if we are very lucky, then we see some very small active, only extrafoveal polypoidal lesion, and which today also we can treat with the laser treatment along with anti-VEGF treatment. And so many times we are seeing that these IPCVs are associated with a large submacular hemorrhage in which either pneumatic displacement of that blood or with or without vitrectomy and with and without TPA is required. So this is the short guidelines from APVRS. So monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as only monotherapy. So far, we have a very good data of aflibercept comparing with the other types of NVD, comparing with the other agents and comparing with the association of PDT. So far, other newer generation anti-VEGF drugs like faricimab and brolucizumab, they are also doing very good. They are also having very good results in treatment of AMD and PCV. But as such, now we don't have any data, comparative data as a monotherapy that shows that these are like non-inferior to combination therapy in patient with PCP, unlike aflibercept. So 2016 was a very pivotal point for the treatment of this PCV in ARMD. As I told you earlier that previously when we diagnose the patient with PCV and AMD, that means we have to give multiple dose of anti-VEGF injections. Patient has to be mentally prepared that so many injections are required, probably a month and a two, right? And sometimes it is has to be associated with the PDT. Again, PDT, it was a gold standard treatment along with the ranibizumab that time before 2016. But after these various studies of aflibercept, it has come as a like one of the choice of agent because most of the clinical trials of aflibercept they demonstrated that PCV can be treated similarly like a regular age-related macular degeneration, right? So here some results are there of View 2 study and Planet study, and it shows that comparative results in both PCV as well as non-PCV group. You can see here that in non-PCV group, there is an improvement of the ETDRS 9 letters while 11 letters in a PCV group. So these data are very comparative, in fact, better than the non-PCV group. So patients with PCV and patients with neovascular AMD achieve similar vision gain with aflibercept monotherapy. Here, the study shows about the Planet studies, and it also shows the same results that aflibercept 2 milligram and along with the rescue PDT is given, and it shows the comparison with aflibercept 2 milligram given as a monotherapy, and still there is a gain of 10.7 ETDRS letters compared to 9.1 in associated PDT. So PDT can be reserved as only a rescue therapy for a suitable patient when it is not responding to anti-VEGF monotherapy alone. So here there is a short description how the study was planned. So Planet was a prospective sham control study assessing the efficacy of aflibercept monotherapy, and it compared with the results of aflibercept plus active PDT for the treatment of PCV in neovascular AMD. So there were total number of 318 patients. This was a double mask multi-center study which has taken place around the 62 centers. And in all the patients, there was a common protocol initially that the monthly loading dose of 3 injections, so at the interval of 4 weeks, the aflibercept 2 milligram was given. And then after the study group was divided into randomizedly 1:1 ratio. So after 12th week, the one group was assigned, and in that group, the aflibercept 2 milligram was given every 8 weeks as a only monotherapy, right? And if some criteria of rescue treatment means like sudden development of new hemorrhage, or there is a new development of SRF, or there is an increase in the problem, sudden loss of vision, then in one group, that group was given, instead of 8-week interval, that group was given aflibercept at the interval of 4 weeks, along with sham PDT. So no PDT was performed in that group. And in the another group, the same protocol initially, aflibercept was given at every interval of every 8 weeks. And when the rescue criteria meets, then say such patients underwent aflibercept at the interval of every 4 weeks along with active PDT. So this protocol was maintained up to 52 weeks. And at the primary endpoint, again, the assessment was done from the baseline visual acuity and OCT. And this study continued up to 96 weeks. And after 52 weeks, again, the one group, the first group, probably it was given the treat and extend group or rescue group defined as aflibercept every 4 weeks or sham BDT. And another group, again, it was given on TNE basis and defined as aflibercept at every 4 week and then active PDT. So the study continued till 96 weeks and the results were identified. So these were the basic results you can see in the PANES study at the interval of 52 week and 96 weeks. So what you see in the dark, that is basically aflibercept 2 milligram monotherapy. And what you see in the lighter blue color, that is aflibercept along with the PDT. So at the end of 52 weeks and also at the end of 96 weeks, you can compare both the results. So results are almost same in both the groups. So that's why we can say that PDT is actually not very much required, and anti-VEGF monotherapy, aflibercept monotherapy has as equal role in treating the PCV in neovascular AMD. Now, if you compare the number of injection in this number of aflibercept injections, so during the first year, the trial, the average patient received 8.1 injection, and after 52 weeks, that means that during the second year of the trial, the average patient received 4.6 injections. So now this patient, if we extended the interval of interval between two anti-VEGF injection, like in the first group, it was a subgroup. It was the injection was given at more than or equal to 10-week interval till 96 weeks, and in the second subgroup, the injections were given, anti-VEGF injections were given at more than or equal to 12-week of interval. So even this such a long duration between the two injection, the aflibercept monotherapy, the vision gaze was compared with the group of the PDT. And here you can see the improvement in the ETDRS letters is almost same as with the compare with the PDT treatment here. And the number of injection here same. The monotherapy, the group required 4.1 injection per patient, and in the other group it is 4.4. So these numbers are quite comparable. And even in the second subgroup, if you can see the plus 10.5 later improvement plus is plus 11.5 liter. So it is again almost the same. And the number of injection required during the second year, it also same. So that means that previously what we had believed that whenever there is a PCV, we had to give lot of intervals. But now with the aflibercept, we can reduce the number of injections. We can also increase the duration between two injection. And that all too with a great number of improvement in ETDRS later and reduction in macular thickness. So overall, this will definitely reduce the burden on patient and healthcare system. Again, these data are also supported by some another real world studies like ALTER, in which this is the data showing PCV subgroup. And again, this is non-PCV subgroup. Again, if we extend the interval of between two injection by 2 weeks, and again, if we extend the interval between two injection by 4 weeks, so the results are almost same and comparable in PCV group versus non-PCV group. That means we can treat now all PCV like a normal age-related macular degeneration, wet AMD, with a very good results with aflibercept monotherapy. This is again the real-world study from Japan. It's a Maruko et al., which shows again similar comparison between the PCV subgroup and typical neovascular AMD group. So again, if you can see the number of improvement of letters on ETDRS chart at year 1 and year 2, it is almost comparable to other non-PCV group of AMD. And if you definitely compare the number of injection, still it is the number of injection 7 in the first year, which is almost same as 7.8, and again during also second year. So not only that, but more like almost in the first year, almost 67.7% of the patient, they reach almost to 12-week interval between the two injections at the year two. And here also in non-PCV group, that figure is 51.1%. So this number is very good if you treat the PCV group with aflibercept monotherapy. Again, this is a different real-world patient study. This is not a randomized controlled trial, but same kind of results we can probably get with the aflibercept monotherapy. If you compare here the number of letters, again the same, the number of basically the injections required at the 12-week interval is almost same and comparable with the aflibercept. Now, this is again, the slide shows the regression of polyp, PCV polyp across all this study of Walt and another studies from Japan. And it shows that there is a total regression of polyp, approximately varying from say 55% to almost high as up to 78% in different studies from 3 months to 12 months. Now, this studies also shows that there is a little bit fluctuation in the number because sometimes the different study have different criteria that how to exactly define the polyp regression. And according to different study, there may be little change in the definition of polyp regression clinically as well as on OCT and ICG. But still, this is a very good number if you compare from 55% to 78% rate of complete polyp regression after the aflibercept monotherapy. So this is again a comparison of clinical trial, which is the main clinical trial for the aflibercept was Planet, and for the faricimab, the clinical trial is the Salvin, and there is a comparison between these two study. So also as I told you earlier that faricimab also has a very good results in PCV in AMD, but the only thing is that they have not comparative data unlike aflibercept in which they have compared with the other PDT or any other agent wise. This was like a single agent therapy and there was no comparison. So still we are waiting for a comparison of faricimab with another molecule. Here there is a study of Hara et al. It also shows that if you give PCV patient the initial three loading dose, these are the very early results of at the interval of initial period of 3 months, and that the 40% of the eyes of this ARMD group was PCV. And if you compare the improvement in the vision in aflibercept treatment was far better than the faricimab treatment in first 3 months. And here in this chart, probably you can see that all eyes with all type of fluid on OCT, if you compare with aflibercept and faricimab, then at the interval of 1 month, second month, and third month, that is the following the injection of first and second and third of anti-VEGF injection, you can see that compared to faricimab, there is a great reduction of decrease in the fluid on OCT compared to faricimab. And still, the initial result shows that aflibercept is a very good role as an anti-VEGF monotherapy. And here also the complete resolution of polypodal region for during the initial 3 months also, the aflibercept is was far superior than the faricimab. So although these results are very early, but we would like to anticipate more studies regarding faricimab. So in head-to-head comparison, the real-world study in treatment neovascular AMD, all patients was from the Japanese population, and both aflibercept and faricimab treatment are effective in reducing exudation and retinal thickness. However, aflibercept was more likely to eliminate exudative changes and improve the visual acuity after the loading dose. So this was about the randomized clinical trial and so many real world trial. And now let's come to real world Indians scenario in which sometimes like we always found difficult to treat patient with AMD or PCV, and it's always difficult to explain patient that to like that let them explain that initial 1 or 2 years they probably require maybe 8 injection or 12 injection, maybe 3 loading injections, and then probably the patient requires 1 injection like every 8 weeks or 12 weeks. So these are some patient, like this is a patient again from AMD and PCV around age group of 72 years. And when the patient came in January 26, it was a massive PCV, large irregular PED, right? So patient had already received one aflibercept injection elsewhere 1 month before. So at this point, I have given the second injection in January and third injection in the February, and I like again was the patient in the March, and you can see the dramatic reduction of the central macular thickness, edema, and you can see now only PED. Again, when the patient I have called after 8 weeks and I examined the patient in May, again there was little SRF here, although this component was quite stable. But at this time, I have given one more aflibercept injection. So this is the fourth one probably. And at that time, if you can see here, after 1 month of the treatment, as well as the subretinal, and as well as the macular edema. Again, there's a very old patient, and probably this patient's a retired judge, 80 years old, and I have given him, following him from the long back, and this was the first presentation of PCV, very irregular, and as I told you earlier, the M-shaped irregular PED, and you can see there's a massive hemorrhage again here. So at that time, the visual acuity was 6/36. And at that time, we had advised him the aflibercept injection. He has received 3 loading dose. This was the picture again in August. And in between, he went like some of the in between images are not there. But again, August, there was a recurrence. There was again little bit of subretinal fluid here, little bit of hemorrhage here. So at that time, another aflibercept was given. Again, everything was fine till March 24, and the patient presented again in the March 24, again with reduction of the vision to 6/36. Again, the fresh hemorrhage. You can see the lot of edema. Again, same thing can be confirmed with the OCT. But at last follow-up then was in August 24, and the patient was maintaining 6/18 vision. You can see the amount of PED, it's like really flattened. Here there is a no blood actually. Whatever you can see is a old score, the old scar here. Luckily, the fovea has been spared nicely, and the patient, after probably multiple 8 or 9 injection during these years, he is maintaining good visual acuity of 6/18 after this aflibercept injection. So to summarize, aflibercept's 2 milligram efficacy and safety profile has now been very well established across all randomized clinical trials and supported by over a decade of real world monitoring. So far, there's been almost greater than 20,000 patients from greater than 20 countries have been treated in all these real world studies. The actual data shows that more than 90 million doses of aflibercept are given in more than 13 million of patients, right? And it shows that very wonderful improvement in the visual acuity as well as reduction in polyp. Not only that, the rate of intraocular inflammation is very, very low compared to other molecules. It's 1 in 10,000 units sold, and rate of endophthalmitis is almost 0.6 in 10,000 units. So aflibercept monotherapy has now become a gold standard for treatment of PCV in neovascular ARMD. We can now reduce the lot of doses of ARMD. We can reduce a lot of burden on the patient side and healthcare system with a very good visual improvement. So thank you very much to all of you for kind listening. And yeah, over to you, Pratik.
Yeah. Thank you, Shalin sir, for the wonderful talk. Our next presenter is Dr. Priyanka Kole ma'am. So she is a consultant ophthalmologist and eye surgeon based in Indore, dedicated to providing advanced ophthalmic care and vision restoration. She holds a postgraduate specialization in ophthalmology with specialized clinical training in modern cataract and refractive procedures. Her clinical expertise covers comprehensive eye examination, phacoemulsification, glaucoma management, and medical retina disorders. She has actively contributed to clinical research and presented papers at various states and national ophthalmic forums. Known for her patient-centric approach and precision in microsurgery, Dr. Priyanka continues to expand access to highly quality modern eye care for patients across India and Central India. Uh, Dr. Priyanka will be giving a talk on diabetic macular edema from understanding to treatment. Yeah, ma'am. Ma'am, please, over to you.
Yeah, a very good evening to all of you. Thank you, Pratik ji. Now, let's start. We'll discuss today about the diabetic macular edema from understanding to the treatment. So, first we'll discuss about what is DME. DME is the presence of excessive fluid in the area. One second, it was going again and again. Sorry. Is it visible? The slide is visible?
Yeah, ma'am, it is visible. So we are able to see vision loss in the patient with DME.
Okay, but it was not visible on my.
No issues, ma'am. You can skip.
Okay. The slide was not changing actually. Why?
मैम एक बार अनशेयर करके फिर से शेयर करिए प्लीज. Yes, now it is unshared. Yes, ma'am, we can say see the screen. Slide share mode. मैम F5 दबा दीजिए सो स्लाइड शेयर हो जाएगा.
Okay. So today we'll discuss about the diabetic macular edema and their treatment part. So it is expected that the global burden of diabetes will continue to rise as we can see here in all over the world. In Southeast Asia, including India, we are getting daily lots of patients suffering from diabetes, and most common complication of diabetes is diabetic macular edema. So it was
मैम just a minute, मैम आपका स्क्रीन है ना स्लाइड शेयर पे नहीं है, so
Okay,
we are able to see your entire screen. So there is a pop-up box also we are able to see.
Yeah.
Pratik bhai, if possible, you can share the screen if you have the presentation.
Now it's visible.
No, it's not going in the slide share
Ma'am, वो actually
presentation mode.
yeah.
अभी no.
PowerPoint पे नहीं है मैम, ये MS PowerPoint पे नहीं है. You have opened it via Google Slide. मैम इसके पहले आपने MS या PowerPoint पे किया था.
हाँ, मैं वही कर रही हूँ, बट आई डोंट नो व्हाई वो क्यों नहीं आ रहा. वापस से एक बार देखें.
Yes, ma'am. Now it is full screen visible. मैम स्लाइड मूव हो रहा है?
नहीं, स्लाइड मूव, हाँ अभी हो रहा है, राइट.
Yeah, we can see the next slide.
Yeah. So, what is DME? DME is the presence of excess fluid in the macular area of the retina and can result in the loss of visual function. So, DME occurs when the blood vessels in the retina leak fluids and protein into the macula, causing the macula to swell and hence result in the affect the visual function. So, VEGF-A plays a key role in the pathophysiology of DME. VEGF-A, what it did was it increase the permeability and it disrupt the blood-retinal barrier in the DME, which finally leads to the moderate to severe visual loss in the patient with diabetes. And most commonly, it involves the working age population in the most developing countries. It can affect both, like type 1 diabetic mellitus patients and type 2 diabetic mellitus patients. In both class, they can affect. So, what are the vision loss in the patient with DME can have life-changing consequences. So, patient with DME are typically of working age. So, vision loss that produces the independency, productivity, and the ability to perform daily function can have a drastic impact on their lives. So, like they are having difficulties in driving, reading, doing near work, and perceiving the colors. Also increases the mortality rate, and patients are end up into the depressions and all. So if we can't see a DME or we can't treat a DME on time, if we'll left untreated, the DME can affect so badly, so it can lead to the severe visual impairment and blindness. As you can see in this image, there is a normal macula, and in case of DME, the fluid accumulates in the macular area and results in the swelling. Here in the fundus photo, you can see there is a microaneurysm and intraretinal hemorrhages in the yellow circle. And in the red circle, you can see the lipid exudates often disrupted in the succinate pattern around the leaking microaneurysms. So, the treatment of visual impairment due to DME has evolved over the time. Initially, it was only laser is the gold standard, but as over the time of period, anti-VEGFs are now the gold standard for the treatment of DME. Over the years, in 2021, we'll get ranizumab for DME. Then in 2014, we'll get the aflibercept. In 2022, faricimab came, and in 2023, we'll get that 8 mg of aflibercept approved for the DME. So, what factors drive key mechanism behind the pathogenesis of DME? So, VEGF-A and VEGF-F can act via the VEGF receptors to promote the vascular leakage, edema, inflammation, and the neovascularizations. So, VEGF-A acts via the VEGF-R1 and VEGF-R2, and VEGF act both directly via the VEGF-R1 and indirectly via the VEGF-R2 by displacing the VEGF-A from VEGF-R1. So excessive activation of these factors, factor R1 and R2, can result in the increased vascular leakage and finally leads edema, inflammation, and pathological neovascularizations. This chart also explains the same that because of the impaired retinal blood flow, it will lead to the hypoxia. And due to hypoxia, the VEGF activates the VEGF-R1 and the VEGF-R activates the VEGF-R1 and 2. So this can lead to cause the inflammation, increase the vascular permeability, and causes the neovascularization, which finally break down the blood-retinal barrier, and hence the visual leakage and edema occurs. So in this picture, you can see the aflibercept is the only global available anti-VEGF agent that targets the multiple mediator of retinal diseases. How? Here, like in ranizumab and brolucizumab is acting only on the VEGF-A, whereas aflibercept, you can see it acts on all the mediators like VEGF-A, VEGF-B, and VEGF. So even if VEGF-A is completely blocked, the VEGF-B and VEGF would still be able to blind their receptors and therefore contribute into the pathological effects. But in case of aflibercept, it can block all the three mediators. So this is the most globally available only drug in the market. So to summarize, VEGF-A, VEGF-B, and VEGF are the key drivers behind the pathogenesis of DME. And aflibercept is the only globally available anti-VEGF agent that targets the multiple mediators of retinal disease. So several sources of evidence support the anti-VEGF choice for the patients, like through RCT, through the real-world evidence, to the network meta-analysis, individual international guidelines, and the individual doctors' experience also. So it is important to provide the timely and effective treatment for all the patients with DME and ensure that the vision gain are maintained in the long term. So what did Vivid Vista shows about the impact of aflibercept in DME? So Vivid and Vista are the two studies which was done in USA and out of USA also to get the approval for that aflibercept in the treatment of DME. So it is clinically meaningful vision gain were achieved in the patient who receive early intensive treatment with aflibercept. In this, you can see there is a mean changes in BCVA from baseline through the week 52 primarily. Like the gray graph is showing that the patient is getting only laser treatment. The yellow is indicating the aflibercept in 4 weeks interval. The blue triangle part shows the aflibercept in 8-week intervals. So as you can see, if we give the initial 3 injections, the best corrected visual acuity was increasing, like the patient is responding so well, and it can continue till the 5th injection, and it will maintain the vision improvement day by day and week wise. In Vista, you can also see here by after giving 3 injection and injection 5, the plus 12.5 correction will be there for now. So mean number of injection in year 1 is the in aflibercept in 8-week interval was 8.5, and in 4 weeks interval is 12.2 in Vivid. And in Vista, the mean number of injection in year 1 is the full cohort is the aflibercept. 8 weeks is 8.4, and in 4 weeks is 11.8. So in Vivid and Vista and Protocol T, these are the another study, clinically meaningful vision gain were achieved in patients who receive early intensive and treatment with aflibercept. So the vision gain can observe patient receiving more than 8 injections through year 1 and maintain vision gain achieved during the initial loading phase. Across all 3 studies, patient treated with aflibercept gained on average more than 10 letters. And at the week 52 primary endpoint, aflibercept demonstrated superiorly to the laser in Vivid and Vista. So Vivid Vista delaying the aflibercept also shows that the delaying in aflibercept therapy lead to the poor vision outcome. Here you can see the patient in the laser group were eligible to receive the aflibercept PRN from week 100 if they met predefined vision loss and OCT criteria. But there is not much showing the great results in the BCVA. So 48% and 46% of the laser controlled eyes receive aflibercept RPN from week 100 to week 148 in Vivid and Vista respectively. So what do the next one is the meta-analysis and expert international guideline recommended for the treatment of DME. Here the Cochrane meta-analysis reviewed evidence from the major studies investigated the efficacy of anti-VEGF agents in DME. So at year 1, all efficacy outcomes significantly favor the aflibercept over ranibizumab and bevacizumab. Then patient were approximately 30% more likely to gain more than 3 lines with aflibercept than the other anti-VEGFs at 1 year. Anti-VEGF agent did not differ regard the side effects at year 1 or year 2 of follow-up. The other meta-analysis suggests that aflibercept is the most favorable treatment for the patient with DME. Aflibercept 8 weeks interval consistently showed the evidence of superiority compared with the ranibizumab for mean change in BCVA. So, will gain of more than 15 EDTRS later and loss of more than 10 EDTRS later from baseline to month 12. Here you can see the aflibercept, the most favorable treatment in the term of BCVA improvement and CMT reduction compared with the other therapies in the management of DME within 12 months. So there are another international guideline recommended. They are following EURETINA guideline of 2017, Asia recommendation of 2018, Diabetes Canada guideline 2018, and the German Ophthalmology Society guidelines. They all stated that the aflibercept is the drug of choice in DME eyes with the baseline BCVA below 69 letters, and it can improve the result more rapidly than the other drug. So can these guidelines and meta-analysis inform anti-VEGF treatment in clinical practice? So there is data from the Moorfield Eye Hospitals and the FRB registry assess the efficacy of aflibercept in the patient in clinical practice. The poor baseline visual acuity is common places is up to 2/3 of the patients in clinical practice. And the adjusted mean visual acuity gain from the baseline to month 12 in eyes with initial vision of less than equals to 68 letters was significantly high in eyes receiving the aflibercept than the dose receiving the ranibizumab with a similar number of injections. So, VIBIM as the treat and evidence with the aflibercept initiated in year 1 can provide the clinically meaningful visual outcome over 2 years. Mean number of injections from baseline to 2 is 14.4, and in this the mean changes in the BCVA from baseline to year 1 is plus 6.1 letters. Patient completing the 2 years follow-up, that is 75%. So BCVA at years, you can see that baseline to type 2, 66.7% of patients were on 16 weeks interval treatment at the end of 2 years. So JADE is another study which can state that the aflibercept treat and extension initiated after 5 monthly loading doses provided significant visual acuity improvement in the patient with DME. Mean number of injection over 52 weeks is 7.7, and here you can see the last injection interval at week 52. It means 89% of the patient had a last injection interval of 12 weeks. So to summarize, aflibercept can achieve the meaningful vision gain in the patient with DME as demonstrated by the RCTs, meta-analysis and international guidelines and recommendation, suggest the aflibercept should be the drug of choice when treating the patient with baseline visual acuity less than 69 letters. And the real world evidence highlighted the effectiveness of the aflibercept in the clinic where patients regular presence with the poor baseline visual acuity less than 69 letters. So patient with the visual impairment due to DME, particularly those with the baseline BCVA is less than 69 letters, can achieve meaningful vision gain with aflibercept compared with the other anti-VEGF agents in the real world clinical practice. That's it. Thank you.
Yeah, thank you, Priyanka ma'am, for this wonderful talk. Ma'am, we have one question. This is an open question for both of you speakers. So what is your preference as in first line drug in PCV since many drugs are available in the market?
Yes, of course, as we have discussed, like aflibercept is one of the leading drug in the market, but in the real world scenario, most of the time the patient depends, the choice of drug basically depends on the cost of the regimen. So that comes to definitely a major role in our clinical scenario.
Okay.
So far, at least for PCV, at least I would like to ask other speaker also. I don't have any experience of 8 milligram dose usage in PCV, but of course, I'm very comfortable with the standard aflibercept.
True, sir. That's true.
Sir, we will be launching this 8 milligrams by December. So by
Okay.
January onwards, it will be available for the commercial market. So still, we have not marketed in India. So we have very less experience. So I guess madam is also not experienced 8 milligrams as of now.
No. Until now, no.
So I guess no more further questions, sir, in the podium. So once again, I would like to thank Dr. Parekh for giving a wonderful talk, and Dr. Priyanka ma'am, thank you for a wonderful talk. And I would like to thank all the participants, those who have spared valuable time for this scientific. So thank you everyone. Good night.
Thank you very much. Thank you, Pratik, for moderating the session. Thank you, sir. Thank you, ma'am, for joining the meeting.
Thank you so much. Good night.
Yeah.
Okay, sir, can we end the session?
Yes, please. Thank you.
Yeah.